So I think we'll go for the subsequent session. This is bout number 20. Next session is bout number 20. This is the last session before lunch. This is on lipidology. And I would like to invite Dr. Kamlesh Upadhyay, Dr. Dhiren Joshi, Dr. Vijay Pai as chairperson, and co-chairpersons are Pankaj Talokar, Kinjal Bhatt, and Dr. Atul Baisar, Atul Parikh. I would like to request Dr. Dhiren Bhai to kindly introduce speakers.
At the outset, I congratulate and thank Dr. Kamal for giving me the opportunity and organizing such a fantastic conference in which every clinical situation is put in a question and multiple options, and then coming to a conclusion in a physician's perspective. This is really a good design of this trial, and really I congratulate Kamal for that. Now coming to the bout number 20 regarding the diabetic dyslipidemia. I invite the first speaker, Dr. Praveen Chandra from Delhi. He is MBBS, MD and DM cardiology. He is chairman of interventional cardiology at Medanta Medicity, Gurgaon. He has been awarded for success and achievement in the field of medicine with Padma Shri by the President of India. Also served as a director of cardiac cath lab and acute MI service at Max Hospital. He is a consultant cardiologist at Heart Institute. He is a fellow of Endovascular and Interventional Society of India.
Thank you.
He is distinguished faculty member in various international meetings. He is the organizer and director of AMI course held in New Delhi from the year 2006. He has published ample of articles, reviews and abstracts in various prestigious national as well as international journals. So Dr. Praveen Chandra. Second speaker.
Dr. Atul Bhai, you can introduce another two speakers, Dr. Rajiv Agrawal and Dr. Ramesh Goel.
Atul Bhai.
Dhiren Bhai, you can only introduce them.
Hello. Am I audible now?
Yeah.
Yes, Atul Bhai, please go ahead.
Yeah. Please, Atul Bhai. Please go ahead.
He chairs the Department of Cardiology, I'm talking about, and he works equally in preventive and invasive cardiology. He has deep interest in the vascular biology. His department is bigger referral base in India. He was awarded Amar Ujjan National Excellence Award. He is inspiring doctor for India and health icon facility for lifestyle server by the Times of India, and he has literally excellence honor by 2018 by Bharat Nirman, a private NGO since 1980. The third speaker is, can I have the data of the third speaker, please? Our third, hello. Dr. Rajesh Goel from Apano, Ahmedabad, is MD/DM endocrinology, senior consultant and HOD Department of Endocrinology and Diabetes at Apollo Hospital. He is a faculty at so many places. He is a former member of the National Advisory Board of Indian Journal of Endocrinology and Metabolism. He was awarded as Best Diabetologist in 2018 and Best Endocrinologist in 2018-2019 in Ahmedabad, Gujarat by Times Health Icon, conducted by Times of India. Thank you, Jayesh Bhai.
I want to share my screen if you allow.
Please share, sir.
Thank you, Dr. Kamal, especially, and all the organizer for taking me in on this very important aspect, which is very close to my heart. I think nature is kind. I superseded Praveen Chandra because anthropologically speaking, agitamide came earlier than PCSK9. So if you look at evolution, agitamide should be talked earlier than PCSK9. So I think everybody remembers the case.
तो गधे
This is a
जैसी है,
very
जाने देना
interesting
उसको।
case. This is a very interesting case. I think you have not shown the case. Can somebody put the case on the board, because I have to build up the case.
Dr. Rajiv, I think I have the case on my slides.
Sure. So Praveen, you can come in. You can come in first. Yeah. That's
okay.
very important.
So you can unshare the screen. Unshare the screen.
I'm doing that.
Thank you.
Thank you.
Okay, so here is the case. Okay, now, okay, fine. So thank you, Dr. Rajiv, and thank you, Dr. Kamal, and all the colleagues there in Gujarat, and for this very interesting program on discussions and debates on various day-to-day issues. So here the issue which is in front of us today, that this is a patient who is 57 years of age. He is a diabetic. He has a LDL cholesterol of 112 on Rosuvastatin of 40 milligrams. He had a previous PCI about 8-9 months back to RCA, and he has a strong family history of CAD. And now, after the angioplasty of RCA about 8-9 months back, he comes with a new acute coronary syndrome. And this time they find that the LAD is progressed and it is about 99%. So of course, he is going to undergo intervention, which is without any delay. But now we are going to discuss about his control of statins and protection for future events. How do we do that? Okay, so now let me take you through this case. So now I think everybody will remember this case. And the question here is, what should be the target here for the LDL cholesterol? Whether you should blow it down, how do we do it, and when do we do it? All these questions. And so in this series, what I'm going to share with you a little bit of why it is important. Because lipids are the most critical modifiable CV risk factors for acute myocardial infarction. So this we have recognized for a very long time. And here we have this data from many studies. And also LDLC, which is the building block of atherosclerosis, has to be, so this we have to really strike at the bottom of the whole pyramid. Otherwise, we are not going to gain much benefit. So the data from the CTT meta-analysis showed that the major vascular events versus absolute LDLC reduction, here you see that there is a constant slope which is there. And this is from the 5 trials. And this is like, very, very, I must say, pivotal to establish this concept of bringing it lower and lower. But when we did that with the more trials, the ideal trial, the TNT, prove it, everything. And all of it showed that, yes, if you give high intensity statins, it does reduce events. But what happens? What happens is that we still have some patients who will have events. So it comes from 26 to 22, from 13 to 12, from 10 to 8, but it doesn't come to 0. And what we require is that we want to bring it as low as possible. And if you look at this data, nearly 1 in 5 patients will have a recurrent CV event during the first year post-MI. So why are we delaying things? We have to do things faster. And here you look at the ischemic risk. At 30 days, it is greatest. So post-MI patient, 30 days, the risks are greatest. And within 1 year, the event rates are so high. So the question here is very, very pertinent that, of course, we have to start doing something faster, something earlier. And this is the monotonic relationship between LDL cholesterol and major outcomes. And you look at this, LDLC less than 20, 10% patients had LDLC less than 20. And it shows that there is no safety concern, even if the LDL goes below 45, 50, or comes to 20. So based on all this information, we had the new guidelines. And here we have started looking at the new things, which is the very high risk profile of this patient. So our patient, which was given to us today, falls into the very high risk category. And beyond that, there are additional risk factors in this case. And if you look at this guideline, that in this patient who is at a very high risk, a combination of PCSK9 inhibitor therapy starts coming into the picture. Why? Because he has very high risk, he has acute coronary syndromes. And if you look at this information, that this patient who was already on statins, high dose statins, was 40 milligram of Rosuvastatin, or if the patient was 20 and that was the maximally tolerated dose for him, even 20 is the highest dose for him. And of course, this patient is not on ezetimibe, which will be discussed, but ezetimibe just becomes the second drug to be added in these patients. But we will discuss more that why PCSK9 also becomes a natural second drug in this particular situation. So PCSK9 has come to a very important stage where if the LDL-C goals are still high despite maximum medical therapy, and if this patient has come within 1 year of the first intervention, he's receiving the second intervention, he starts coming into the picture of addition of PCSK9 therapy. Even if the ezetimibe has not been added, we can start that. And all this has to happen much faster than what we were thinking earlier. So this is our indoor patient. And if you look at the research of the last 25 years, 30 years, what we see is progressively we found that high cholesterol was bad, average is not good, lower is better, and even lower is even better, and lowest is best. So we have to bring down the cholesterol. And why we should use PCSK9? Because it reduces the cholesterol maximally. If you look at the 140 milligram of evolocumab given twice a month, it reduces cholesterol by 64%. Compared to ezetimibe alone, it just gave rise to 24% reduction. And if you combine it with statins, still it is lesser than PCSK9 combination. So that is the most potent agent. And we have to start thinking of the most potent agent in this particular very high risk situation. So PCSK9, as you all know, I won't go into this, that it just prepares the LDL receptors. It stops the interaction of PCSK9 to LDL, and the LDL particles removal, which happens through these receptors, is enhanced, and the LDL reduction starts very quickly. Within 2 to 3 doses, we get a steady state. So which means the action starts rather fast. And the dose is, as most of you know, 140 twice a day or 420 once a day. And this is the average reduction of cholesterol. When we combine high intensity statin with ezetimibe, it comes to about 6. High intensity statin, it comes to 75%. And when we combine all the three, it is 85%. So this is the particular situation where I think this patient will require all three of them. So it is not that I'm saying PCSK9 alone. Ezetimibe also should be added to this armamentarium for this patient. So the evidence started from chronic coronary syndromes from the Fourier trial, which was the most important, but that is not pertinent to us right now. The most important thing is the subset of patients from Fourier trial who were high risk and who get the maximum benefit. And these are the patients who are high risk, qualifying MI less than 2 years. So our patient is in this category of less than 2 years. You see the benefit is maximum. So we have to use this. More than 2 prior MIs. Again, this patient is the second MI, falls into this category, gets the maximum benefit. So this patient has multivessel disease, again gets the maximum benefit. Although we are deriving all this information from the Fourier trial, but we can extrapolate all this information very easily onto this patient. Then the MACE event in patients with and without PAD, of course, in PAD, if the patient also has a PAD, which we'll have to find out, then this patient will definitely get benefit from this therapy. And those patients who have previous prior PCI will again have a better outcome compared to those patients who do not get evolocumab. So you can imagine this patient is a very high risk patient, and all these patients who are previous bypass surgery, complex PCI, and complex revascularization get more benefit when PCSK9 is added to this patient, to this therapies. And of course, the safety of this therapy has been established quite well. And the safety events has been also adjudicated and found to be much safe, and there's no issues in terms of safety of adding this therapy to our patient. Then go to the acute coronary syndrome subset of patients. And if you look at the acute coronary syndrome subset of patients, the first trial which comes in the picture is EVOPAX. In this study, where these patients came with unstable angina, less than 24 hours, and here or less than 72 hours of ST elevation MI. This was patients who were given evolocumab in the hospital. And look at the change in LDL levels at 8 weeks. It was substantially different. P-value was significant, less than 0.001, and the reduction of LDL was very, very consistent. In the EVAC study, another study for acute non-ST elevation MI, given evolocumab in the first initial hospitalization, LDL reduction was quite significant and rapid. At day 1, between day 4 and 7, it was 60%, and at day 32%. So you can imagine how fast and how quick we are able to protect this patient from a second event or any other untoward incidents. So guidelines recommended LDL-C targets applicable to ACS can be achieved in most patients at hospital discharge and can be continued. And this is the level of small. If you look at the with evolocumab and without evolocumab, the difference is quite significant. LPA levels reduction is also quite significant. So basically, adding PCSK9 becomes a reasonable strategy for patients coming with multiple events like our patient, recurrent MI, recurrent interventions. All this falls into this category. Then risk for non-culprit related recurrent MI was that twice that of culprit related recurrent MI over a long period of time. And here you see that it was actually the non-culprit vessel which has come, and that is why it is important to treat these patients much more effectively. And there are many studies, intravascular ultrasound guided studies, and then of course showing that lowering LDL and plaque regression is hand in hand. So if you reduce LDL, it really makes a difference, even angiographically or intravascular ultrasound wise. This is another study showing lipid core burden index going down in quite significantly if you give PCSK9 therapy to these patients. And the OCT trial also showed that the thin cap fibrous atheroma, which is the culprit, is also treated well if you give them PCSK9, because in this study they showed that the cap becomes thicker at 12-week follow-up, which means the chance of having MI is reduced. And that is what we are interested in. And many other studies like this angiographic study also showed that the vulnerable plaques can be stabilized after ACS if they are given therapy with evolocumab over an initial period and then continue. So we can modify this residual risk by adding this therapy, and it has been shown. So the three concepts of lipid lowering strategies to reduce events is start early, treat much more aggressively, and use combination therapy where PCSK9 and NSTEMI both are to be added. Definitely in this PCSK9 definitely should not be missed out. And based on the all the evidence which we have, LDL-C should be lower, the better, and it should be less than 55. And in this patient, it should be less than 40, and it should be started in the hospital. One should not wait for 4 to 6 weeks in this patient, and the effect on LDL-C should be checked at 4 to 6 and also at 4 to 6 weeks as to what is the situation. And the lipid core burden index, the fibrous cap, everything improves, and the 5-year safety data of this therapy is available. So one should not worry about giving this drug to our patients. So this is the group of patients in my practice who will be benefited in
the last 1 minute.
Giving PCSK9 disease and multiple interventions like we see in this patient. So to just summarize, PCSK inhibitors are proven and better strategy in recurrent MI, recurrent coronary interventions, and of course in patients who are having uncontrolled high cholesterol levels despite highest dose of statin therapy. Thank you very much.
Thank you, Dr. Praveen, for presenting such crystal clear evidence for PCSK9. I think I have to move forward in a very simple mathematical way, how I look at the case. This reminds me of a very famous quote from Alvin Roth: disease is more expensive than health. And you can imagine a patient having a repeat procedure is a bigger health burden and emotional burden. I'm very emotionally upset with the natural history of the disease in this patient on account of social reasons and account of clinicians inertia who may be an interventionist or a clinician or a clinical cardiologist. My take on this patient is there is a family history. The patient was on high intensity statin, and the consultant was not aware the difference between high intensity statin vis-a-vis high intensity lipid lowering therapy. So I call it is inertia versus ignorance. I'm not aware whether the lesion was existent in the artery before or it is a de novo LAD disease. By no stretch of imagination, a patient who is post-angioplasty should in follow-up have an LDL of 112. It is gross inertia versus ignorance. The baseline LDL 257 reminds me of reduce it, which was not practiced in this patient. There is a very famous table, if you want to go through, which is available from Dutch Lipid Clinic Network score, where you can calculate the current statin dose and a multiplication factor to decide the baseline LDL. The baseline LDL with multiplication score of 2.3 into 40 milligram of Rosuvastatin calculates the LDL of 257, which is alarmingly very high. The LPA is 60 milligram, repeat procedure in less than 1 year, no mention of CRP and BMI in a patient who has recurrence of disease. HbA1c is 7.4. My patient is diabetic, and I'm not aware whether my patient is a part of polyvascular disease or a coronary artery disease. With this background, let me profile you the Improve It trial in brief. Ezetimibe, when used with simvastatin in Improve It, showed a mortality reduction of 5%, absolute mortality reduction of 5%. No intervention, medical or surgical, has shown absolute risk reduction of 5% in diabetics. So let me say it is a dictate that ezetimibe should be used in every diabetic patient. If you look at the polyvascular disease, which is referred by Dr. Praveen Chandra also, you find that as the LDL goes down as low as 55, first time in the history of LDL lowering, there is a continuous reduction in events and mortality. If you have polyvascular disease, you do better. The event rate is more in polyvascular disease. Not only first event, but multiple events when taken into consideration, there is progressive protection. So let us forget about the first event. There is a marked reduction in total event. Reduce it like we talk this phenomena in newer heart failure trials. As the disease burden increases within the heart from single vessel to multiple vessel or triple vessel, the outcome improves. So more the atherosclerotic burden inside the heart or outside the heart, the outcome improves. If you have a polyvascular disease with diabetes, the absolute risk reduction of 9% over a period of 7 years, giving an NT of 11. Once again, if you have patient like this, there is no intervention which gives this kind of absolute risk reduction. Another thing which was very important outcome of this trial was there was no glucogenic signal. So for the first time, we learned that non-statin drug works, and they work with better safety. That means they are not glucogenic or diabetogenic. Then I must, in the same breath, continue to extend it to newer hopes. And this is a recent study which shows that if you combine generic rosuvastatin and ezetimibe, unfortunately, PCSK9 is not generic. The two molecules which I am talking, they are generic, they are cost effective and improve the compliance. Then the LDL less than 70 is achieved in 80% of patients when combined with ezetimibe vis-a-vis 30%. So it almost doubles the patient population, which brings down to significant level of LDL. This is another way to look at it. When bempedoic acid is combined, again, there is 90% patient achieve less than 70%. I'm taking it PCSK9 versus oral therapy, cost versus less cost. And not only this newer drug, this bempedoic acid is not diabetogenic. So the two things which are very important with bempedoic acid and ezetimibe is they're both non-diabetogenic. They both decrease CRP on top of each other. So if the patient has got inflammation for the cause of recurrence, I think they are the very good drugs. Where to go? Like this patient has an event within 1 year, so we have to achieve 50% or less than 1 millimole as per European guidelines. This is our paper in clinical lipidology. We talked less than 30, which is a 4-year data in extreme risk group if the recurrence happens within a year. So this qualifies for extreme risk group category B. And if you look at the guidelines, ezetimibe on top of a statin is 2A because we have only one trial. If you combine PCSK9 with the statin, ezetimibe, this is class 1A indication. But if you combine statin or PCSK9 without having ezetimibe, the indication goes down to 2A. So I'll say it is a mandate to combine high-dose statin and ezetimibe, then think of PCSK9 if you are not achieving the ideal ultra-low level of LDL. This is the latest guideline which has come from Middle East, which are very, very visual and impressive to look at. As the risk category goes down, the values for LDL-C, non-HDL-C goes down. So another way to look at it, but it is very, very visual to understand. One thing which is very important and we should carry home, that if you reduce the LDL 50% or more, the residual risk is almost same, irrespective of the baseline LDL level. So we should know beforehand, once we are starting a lipid lowering therapy, that we have to achieve at least 50%. And if you achieve 50% LDL reduction, the residual risk is not much different in different classes. That's why I say it is a mathematical equation that how much LDL you have to receive, 50% or less than 1 millimole, whichever is lower should have been the target in this patient. And that is why I feel there is a lot of inertia and ignorance on the part of clinicians who are treating this patient. I will think in this patient because it's a very high risk, upcoming concept of zero LDL hypothesis. How do we achieve? We know diamond approach in hypertension. We know diamond approach in heart failure. We know diamond approach in chronic stable angina. I think we should start thinking on diamond approach in lipid lowering therapy. I am trying to make it simpler. What Dr. Praveen showed, that high dose statin vis-a-vis with ezetimibe is always almost similar to PCSK9 alone. So if you feel that 60% reduction of LDL in your patient will amount to 50% reduction of baseline LDL, I think PCSK9 is out of picture to begin with. If you feel that will fall short of your need, then naturally PCSK9 should walk in and should walk in as early as possible. That is how I can make it as very simple. So once again, if 60% reduction in LDL is the need to achieve 50% LDL reduction, you should not think of PCSK9. If you feel you will fall short of that, then PCSK9 should walk in on board as early as possible. Another very fascinating study which has come very recently, that ultra low level of the high level of LPA, only they make a difference when you have achieved LDL less than 70. If your LDL is more than 70, the LPA does not play that much of a risk role. Because LDL is a bigger factor to challenge. If LPA is less than 70, higher LPA translate into higher events. And that is what I am trying to show, that if the LDL is achieved and your LPA is high, then these patients are better off with LPA lowering therapy. Why I am talking this will be clear to you in next slide. Let us imagine a patient who is achieved 70 milligram LDL with statin and ezetimibe, is still falling short of LDL goal. CRP is high. I'll probably choose bempedoic acid in this patient. If my patient is a statin ezetimibe is still 70 and LPA is still high, I will choose PCSK9 because both the drug on the left side, they are not LPA lowering. And fortunately, ezetimibe, bempedoic acid, and PCSK9 are not glucogenic. So they are good drugs to use in diabetic. As many of you must have seen, there is a concept of hyper and hypo responders to statin. We don't have SNPs to clearly define that, but you will know that there are many patients who with medium dosage drops down to 30. I call them hyper responders. And there are some patients who do not respond that well. So don't feel discouraged and try to see how the genetics play in these patients. And many of your patients with moderate intensity statin and ezetimibe will drop down to 70 and they are hyper responders. And I'll say it is good idea to wait for 4 to 6 weeks before starting statin PCSK9 to see whether your patient inherently is a hyper responder or not. I am a strong believer in regression of atherosclerosis, and I want to pass on this message to my colleague. Believe in this concept. It is the best medication for your atherosclerotic patient, and recurrence so early is lot of inertia. It must be embarrassment to the clinician that why my patient is coming so early in the natural history. Within a year, I did less than what I should have done. I coin a new term that we need now metabolic interventionist who can tame lipids and diabetes with perfection, because these are the patients who are benefited most by these interventions. So I feel, let us not feel belittled that I am an interventionist. I am a mechanical cardiologist. I don't understand metabolism. I'll say you are not an atherosclerotic expert, which you should have been. So I'm just showing you some images. This is 6 weeks of aggressive lipid lowering. IVUS images, you can see in B2 image, there is almost no lipid core. And this is 6 weeks. So believe in lipid lowering. They stabilizes, they regresses. And this is a recent hygiene study which showed that these drugs, evolocumab, PCSK9, can increase the fibrous cap thickness and make your plaque stable. Nobody dies of chronic stable angina. Everybody dies of acute coronary syndrome. So one of the aims of lipid-lowering therapy is converting ACS into CCS and ultimately eliminating it. So Shakespeare wrote long back, what is in the name, that which we call a rose by any other name would smell as sweet. I'll modify his quote by saying, what is in the name? It is statin, ezetimibe, PCSK9, bempedoic acid, whatever it is all in the numbers and cost and compliance. So let us not make it again about as you have named it. I'll say we have to make a judicious choice of these molecules. Let us move ahead from boxing debates like we had CABG versus PTCA. Let us start combination therapy like hypertension and diabetes. as early as possible in the natural history of the disease. Let us believe atherosclerosis is a metabolic disease, not a mechanical disease. And I feel we need newer generation of metabolic intervention cardiologists, and we should not believe in artery cleaners, a 1-hour job. And this is what William Osler must have said today. A good physician treats stenosis, a great physician treats the atherosclerosis. Thank you very much.
Now, Dr. Ramesh, go ahead. Dr. Ramesh, go ahead.
Good afternoon, friends. Both the interventional cardiologists have debated with each other, and in that process, they forgot that this is a triangular contrast. And Dr. Rajiv has made my task very easy by saying that there is a need of a metabolic interventionist. And yes, metabolic interventionist is here to present his data on the diabetic dyslipidemia in a context of the patient which we are discussing. So first of all, when we talk about metabolic abnormality linking cardiovascular disease and type 2 diabetes, there is a link between insulin resistance and various metabolic conditions we should not forget. And the classic slide is the YY hypothesis. The YY hypothesis says that at a equivalent BMI, the body fat content in Asians is much higher than the body fat content in a Caucasian. So here you can see Professor Yudkin and Professor Yagnik both are having same BMI of 22.3, but look at the body fat distribution. In Caucasian, it is 9%, and it is more than double in the Indian person. We Asian Indians have low insulin sensitivity compared to Caucasians. So here on the left, you can see insulin sensitivity index, and on the y-axis, you can see the total body fat mass. So at any total body fat mass, the insulin sensitivity index for we Asian Indians is lower than the Caucasians. And similar correlation is seen between insulin sensitivity index and sum of truncals in fold thickness. Insulin resistance is a common link for various metabolic conditions. So here you can see insulin resistance is a common pathogenetic mechanism for type 2 diabetes, and we all know prevalence of type 2 diabetes in India. We have more than 7 crore of diabetic patients in our country. We have a unique atherogenic dyslipidemia profile, and insulin resistance leads to high triglyceride, which can cause CVD. So the prevalence of hypertriglyceridemia in our cardiac patient is as high as 34.2%. And unfortunately, none of my cardiology colleagues even bothered to look at the triglyceride value of our patient, which was more than 300. And NFLD, insulin resistance leads to diabetes and is major risk factor for NFLD. So I will focus more on atherogenic diabetic dyslipidemia. So how does the atherogenic diabetic dyslipidemia influence various lipid parameters? So insulin resistance is associated with elevated triglyceride, and elevated triglyceride leads to increased free fatty acid levels in plasma, leading to hypertriglyceridemia, and ultimately it leads to low levels of HDL and high levels of small dense LDL. And this is the pattern of dyslipidemia, which is different in India compared to globally. So here you can see most common dyslipidemia pattern we see are low HDL followed by high triglyceride. Now let me talk about hypertriglyceridemia, which my cardiology colleagues they conveniently ignore. Elevated triglyceride is a major risk factor for cardiovascular disease, and residual cardiovascular disease risk remains in patients treated with statins, and triglyceride is one of the risk factors which should be kept in mind. So whether we are talking about the heart prevention study or the CARD study, you can see that despite optimal statin therapy, there was significant residual risk, and residual risk was in tune of 70 to 80%. Now I will quote this body 2D study. There is association between triglycerides and residual cardiovascular risk in patients with type 2 diabetes and established atherosclerotic cardiovascular disease. So here in this 2000 plus patients with type 2 diabetes and CAD with a mean baseline triglyceride of around 180, and the primary composite outcome was time to cardiovascular death, MI or stroke, and secondary outcome was cardiovascular death, and with mean follow-up of between 4.5 to 5.5 years. So here we can see higher triglyceride is associated with higher cardiovascular risk in diabetic patient. So on the right side, you can see every 50 mg% increase in triglyceride level was associated with a significant increase in the cardiovascular events. I will quote another study, the pre-diamet study, where remnant cholesterol and triglyceride, but not LDL cholesterol, was associated with incident cardiovascular disease. So trial population was around 7,000 high-risk patients for cardiovascular disease, like a mean age of 67 years, BMI of 30, and 50% of them with diabetes. Median follow-up was around 5 years, and total MACE incidents recorded were around 265. So these are the results, and the results shows that the remnant cholesterol, the triglycerides, and the non-HDL cholesterol contributed significantly to the cardiovascular events as compared to the LDL cholesterol levels. And here you can see, if you categorize the patient with a triglyceride of more than 150 and HDL cholesterol of less than 40 in men and less than 50 in women, then you can see the hazard ratio was 1.5 times higher for cardiovascular events. So triglyceride, non-HDL cholesterol, remnant cholesterol, and even atherogenic dyslipidemia, that is high triglyceride more than 150 and low HDL of less than 40 in men and less than 50 in women, were associated with increased major adverse cardiovascular events. But LDL cholesterol was not associated with incidence cardiovascular disease. The big study showed the 22-year mortality risk for patients with severe hypertriglyceridemia was increased by around 70% when compared with patients with low normal triglycerides. So here you can see, as the level of triglyceride starts moving beyond 150, there is increased risk of the cardiovascular disease. Now, million-dollar question: does reduction in triglyceride reduce the cardiovascular risk or cardiovascular mortality? So I will show some data, the cardiovascular outcome data for triglyceride lowering drugs. First was the field study, 2005. Baseline TG was 155. Fenofibrate did not significantly reduce the risk of primary outcome of coronary events. The second was Accord study, 2008. Baseline triglyceride slightly higher, 162. After a mean follow-up of around 10 years, fenofibrate did not show any cardiovascular mortality benefit versus placebo. But in subgroup analysis, fenofibrate therapy effectively reduced cardiovascular disease in participants with triglycerides of more than 204 and HDL of less than 34. And in reduce IT in 2019, baseline triglyceride was still high, around 216, and after follow-up of 5 years, EPA significantly reduced cardiovascular events compared to placebo. So cardiovascular death was reduced by 20%, MI 31%, and stroke by 28%. So if initial triglyceride is high, lowering the triglyceride has shown to result in the cardiovascular mortality and morbidity benefit. So critical importance of high triglyceride reduction is endorsed by ESC 2019, and here they have quoted that in high-risk patients with triglycerides between 135 to 499, despite statin therapy, the N3 PUFAs like icosapent ethanol should be considered in combination with statin, and The American Association of Clinical Endocrinologists 2020 says that patients with triglycerides between 135 to 499 treated with maximally treated statins who have CVD or DM. So our patient has both, our case patient, plus more than cardiovascular risk factors should receive IPE to prevent the atherosclerotic cardiovascular disease. So what should be the ideal approach to manage diabetic dyslipidemia? So here I am quoting the anti-diabetic medications and the medication used for treatment of dyslipidemia. Each of these drugs are acting on insulin resistance, the root cause of diabetic dyslipidemia. So the answer is only metformin and the glitazone. The second question is, which of these drugs have dual action on both insulin resistance and high triglyceride for management of diabetic dyslipidemia? And the answer is none. So I will talk about saroglitazar. Saroglitazar is a new chemical entity from India, and it is a dual PPAR gamma and PPAR alpha agonist, and more action on the PPAR alpha. So it has a primary effect on the PPAR alpha, and it improves the plasma lipid profile by this biochemical processes, and it has a secondary effect on the PPAR gamma, and by this action it has a beneficial effect in insulin the resistance reduction and glycemic control benefit. So saroglitazar improves glucose metabolism and insulin sensitivity index. So here you can see it is an insulin sensitizer, and it improves the glucose metabolism. And these are the various parameters which are improved by saroglitazar. So here you can see it has a benefit on glycemic control, fasting plasma glucose improved, HbA1c improved, insulin sensitivity improved, and the indices of the beta cell function and insulin resistance as measured by HOMA are also improved. Saroglitazar effectively reduced high triglyceride and improves insulin sensitivity along with beta cell function, and by reducing the glucolipotoxicity, it has effect on the glycemic control and the lipid control. So saroglitazar reduces elevated triglyceride, HbA1c, and the raised liver enzymes in type 2 diabetic patients. And this is the integrated review analysis of 18 clinical studies on more than 5,500 patients. And saroglitazar effectively and safely reduced triglycerides by more than 50%, non-HDL cholesterol by around 20 to 35%, small dense LDL was reduced by 20%, A1C was reduced by 0.7 to 1.6%, and there were beneficial effects on liver enzyme also. And before I conclude, I will talk about the uniqueness of India, and there is a word Gherav, that means encirclement, and this is a word which denotes a tactic used by labor activists and union leaders in India. It is similar to picketing. Usually a group of people would surround a politician or a government building until their demands are met or answers are given, and the Oxford English Dictionary could not find a English replacement name for this, and they had to incorporate the word Gherav itself in their dictionary in 2004, owing to the popularity of this word. So, similar as the case of Indian diabetic dyslipidemia, the Western guidelines, they are focused on LDL, but we should not ignore the fact that hypertriglyceridemia and low HDL are common in Indian population, which is not seen in Caucasian population. And if we are trying, and if we follow the Western guidelines and keep on hammering the LDL cholesterol, ignoring the triglyceride and low HDL, then I don't think we are going to do justice to our patient to prevent recurrent cardiovascular events. So to summarize, insulin resistance is pathological hallmark for type 2 diabetes, but it is also responsible for major cardiovascular risk factors like atherogenic diabetic dyslipidemia and liver disease like NASH. High triglyceride, low HDL commonly observed in Indian patients. High triglyceride is responsible for increased risk of residual CVD, Saroglitazar is first NCE from India, which has shown promising effect on triglyceride, non-HDL, and HbA1c reduction in real-world practice with least side effects. And saroglitazar is first and only drug in world which is approved by NFALD in India by DCGI. So thank you for patient listening. I'll stop sharing my screen.
The house is open for discussion.
Yeah,
We have
all
only
the
5
speakers have nicely given a justification to their respective talks. The one thing which I want clarification and more deliberation from the speaker is that one thing is very nicely depicted by Dr. Goel, that unless we reduce triglycerides to below 150 or 140, even though the LDL is at goal level, the risk because of the atherogenic LDL, means small dense LDL, is going to remain. So for that, triglyceride lowering therapy is absolutely essential, so as we can reduce the small dense lipoprotein even at the same LDL level. That is one thing. And second thing, anybody can comment about the pitavastatin, because pitavastatin is also, as Dr. Agarwal said, that it is we should also consider that de novo diabetes should not occur with the statins therapy. So pitavastatin has got some data regarding that it does not produce any diabetes and its role on this.
Yeah, Dr. Rajiv Agarwal was trying to counter that.
Yeah.
Yeah, please unmute. Please unmute. Dr. Agarwal, you're muted. Please
you
unmute.
are muted. Dr. Agarwal, you are muted.
I'm open now. I'll say, with all due regards for my strong comments, the common sense medicine and evidence-based medicine are they two different things. There is a big JACC review article. Anybody who wants can approach Dr. Kamal. I can send that. There are two different things. Triglyceride is atherogenic at the moment, but there is no data to suggest that it reduces morbidity and mortality. So let me make it very clear to my colleagues in endocrinology, triglyceride is a risk factor, but modification of it does not translate into any kind of gains. I call it cosmetic correction. Like saroglitazar is fine in correcting TGs, but you don't get anything in terms of CV outcomes. So let us make it very, very clear. We are waiting for prominent trial, which will be talking about PEMA fibrate this June 2022. And then we will talk whether the TG interventions play any role or not, like we have failed on HDL front. And the last point I want to make it, reduce it is not a triglyceride lowering trial. Reduce it, use triglyceride as a walk-in criteria, making it higher risk. There is no outcome data in reduce it, which is tertile related to TG. So don't make reduce it as a TG lowering trial. So once again, just to summarize, triglyceride is atherogenic, but like HDL, TG lowering, at the moment, we don't have any evidence. So that is the problem. Thank you.
Dr. Praveen, is Dr. Praveen there? I have a question for him.
I can answer on Praveen's behalf if there is a question.
Sir, how long do we continue giving PCSK9 and how long the benefit remains after giving that?
Atherosclerosis never sleeps. Exactly. So it is lifelong intervention. It is lifelong intervention.
A very costly affair.
That is something, a problem. And I'll tell you, inclisiran is walking into the market, and soon there will be price war between inclisiran and PCSK9, and we will be benefited.
Wow.
Inclisiran we should have in India by this year end.
Okay.
Thank you, sir. Thank you.
I think what you were trying to bring out, Dr. Dhiren Bhai, was the best tolerability is, of course, for pitavastatin. But like this case where we are looking at a CV event reduction, probably these three therapies will do come into play. And yes, you are very right, as Dr. Goyal also pointed out, the residual risk that exists with TG. The TG risk is governed primarily reflective of TG by HDL being reflective of the small dense LDL. If your TG by HDL ratio is more than 3.5, what LDL you have actually reflects a smaller dense LDL, which behaves like 30 mg% higher than what actually it is. So if you have 100 of LDL, but if your TG
that is a very
it behaves like 130, it behaves like 140. So just don't be misled by the numbers of LDL alone. And because we can't do electrophoresis or photochromatography for defining small dense or large dense LDL, looking at TG is an important. And that way, I thought it was trying to pitch seraglitazar, though it does not have an evidence per se in a large clinical trial for an endpoint reduction, MACE reduction, but it does have very sound, robust evidence for reduction in the residual risk targeting therapy in terms of altering not only diabetes, but also managing TG and residual risk that may exist. So that way it's a novel therapy. That's why it was pitched in. But of course, we are not countering it as a therapy of CV reduction, but it does have a strong play when you are dealing with a diabetic dyslipidemia. That's my comment.
But high sensitivity statin with ezetimibe, with seraglitazar will serve the purpose, and it will be lesser costing than the PCSK.
Pitavastatin is a moderate intensity statin, so it has got a very little role in day-to-day management of aggressive lipid lowering. So that is the problem. But if you have intolerance, then today you can have pitavastatin because the enzyme set is different, ezetimibe, bempedoic acid, that kind of cocktail you can serve to the patient and get reasonably good LDL.
Yeah.
So thank you very much. I enjoyed being on with you all. I hope we had some insights into lipid lowering.
Yeah.
It was very nice of you.
Very clear guidelines, and we are clear. Practically, I think all physicians are clear now that what is to be done in such a patients which is presented here.
Truly.
And that this type of patient we get in day in, day out in our practice.
Thank you, Dr. Dhiren Bhai, Dr. Atul Bhai, all speakers. We will go for lunch now, lunch break. And I think within 5 minutes time, we will again restart.
Is there any way the people sitting?
5 minutes.
5 minutes for the lunch. That's
Dr.
great.
Kamal, Dr. Kamal, I want to make a request before you go. Dr. Kamal, I want to make a request. You should send us digital coupons for the lunch.
Sure, we will.
Okay.
Jayesh bhai,
I hope the lunch is then real. It's not a digital lunch just showing the
No,
photograph.
it's a digital lunch.
Thank you very much.
But,
Thank you.
But
Jayesh
all
bhai,
of
let
you
us
are
start
with
invited,
thank you.
those who are at present, Dr. Atul Bhai, Dr. Dhiren Bhai, and Dr.